Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. Iyyaka na'budu wa iyyaka nasta'in. Now we are going to be talking about another cause of antepartum hemorrhage, which is placental abruption. So what was antepartum hemorrhage? The hemorrhage or bleeding from the genital tract into the genital tract or from the genital tract which occurred after the age of viability, which was 28 weeks. So after 28 weeks, this was occurring to define it as antepartum hemorrhage. Now, how do you define placental abruption? Now, the placenta over here is normally situated, okay? If this is the uterus, then placenta is, in its normal location, let's say over here, okay? It is, normally situated, but what happens is that it goes into premature separation. It just separates before time. Normally, when does it separate? Normally, we separate it via the Brand Andrews method during the third stage of labor. But over here, it is separating during any time after 28 weeks. So premature separation occurs of a normally situated. The location is normal. Okay, it is not a low-lying placenta, a normal location, but it is undergoing premature separation. So what happens when it separates? So let's just draw another diagram. Let's say that this is the uterus, okay, and this is the placenta, and it has separated. Now it has torn off over here. So this whole gap is left between the placenta and the uterus, and in this gap blood will accumulate, okay, and as this blood will accumulate behind the placenta, the fundal height will increase because blood is accumulating into the uterus. So if blood accumulates behind the placenta, then this is a type which we called as a concealed type, okay. It is called as a concealed type because all the blood is accumulating behind the torn off placenta instead of seeping out. A little bit seeps out, but it is concealed, and we also call it as a retroplacental hematoma, okay. Retroplacental RP hematoma. I'm just writing down the abbreviations now. But let's say what is happening is it has torn off and all the blood has seeped out, okay, suddenly. Then that type would be a revealed abruption. A revealed abruption is less dangerous than concealed because it is easily, this can be missed. This can be missed or misdiagnosed, so this is more dangerous, whereas this one is easily diagnosed, so that is why you can save the patient. This is why is this occurring when the placenta is separating via the marginal mechanism. If you want to know the mechanism of separation, whether it is central or marginal, you will have to refer back to a separate discussion on placental separation, okay. Then only you will understand that why are concealed and revealed occurring differently, okay. So in revealed abruption, the placenta has separated via the marginal mechanism, and it is less dangerous because you can easily diagnose it because all the blood is coming out. Now, which is more common, whether the concealed or revealed? Most common is a mixed type, okay, in which both things are happening side to side, okay. So what can happen? So let's say the blood is accumulating over here. Now what can happen is that consumptive coagulopathy can occur because placenta is going to release placental thromboplastin, and this thromboplastin is going to seep back into the maternal circulation and can lead to our disseminated intravascular coagulation and consumptive coagulopathy, which can lead to sudden death, okay. And always remember, as I mentioned, in concealed type, since blood is accumulating behind the uterus, this will increase the fundal height. So fundal height will be more than the period of gestation. Always remember this. This is very specific for the concealed abruption. So concealed abruption, fundal height is going to be more than the period of gestation. This is an MCQ point. That's why I'm stressing upon it. Now, as the placenta, separates prematurely, the female can invariably go into labor and labor can start, okay. So this can be the consequence. So what are the risk factors and what is the clinical presentation? The risk factors are almost, similar to placenta previa. What were the initial ones for placenta previa? Increase maternal age and increase order of birth parity, and smoking is a culprit for many things, as I mentioned before. These are common to both previa, to placenta previa and to placental abruption. Now, if there's a prior history of abruption, then there is a 12% chance of recurrence. Now, other than this, use common sense. What can cause placenta to separate? Placenta is present normally in its place, not doing any harm to anything. What can cause it to separate? Any trauma. Let's say the female had an accident, that can cause the placenta to separate, okay. Or if she has antiphospholipid antibody syndrome, or if anything, now this is a very conceptual point, anything which is distending the uterus, let's say that this is the uterus, okay, don't mind this uterus, and this is the placenta minding its own business. Okay. But suddenly a lot of pressure is being applied from all the sides on the uterus and on the placenta because of a distended uterus. Then this distended uterus is going to force the placenta to shear off. Now, what is going to cause this extra force inside the uterus? Anything which is over distending the uterus, such as increased amniotic fluid. So, a condition of polyhydramnios, okay. And another cause can be fibroids. Fibroids can also take up space and put pressure on the placenta if it is present below the fibroids, okay. So, these are all the precipitating factors. If there is multiple gestation, that can also cause over distension of the uterus. How are you going to diagnose what is going to be the clinical presentation of the patient? So it's very easy. I have already differentiated this from placenta previa in placenta previa discussion, but let's just go through these thing again. The typical words you have to find in a scenario are woody uterus. These are not mentioned in 10 teachers, okay? A woody uterus and dark colored bleed. Now, what is a woody uterus? It's basically a tense and a tender uterus. The uterus becomes further painful and tender because labor also starts. Okay, premature labor can also start if the placenta has separated. So, tense, tender uterus is a woody uterus, and it will be undergoing contractions. So, a woody uterus and dark color bleeding, and if any of these are mentioned, painful bleeding, any synonyms are mentioned, then this is a typical scenario of placental abruption. How are you going to approach the patient? The typical things that any kind of antepartum hemorrhage, in any antepartum hemorrhage, you are going to do this: resuscitate the patient, call for help, okay, and you are going to take complete history. The nature of bleed will tell you whether this is placenta previa or placental abruption. The typical signs or the typical scenario points in the history. Now we are going to examine the patient. Now for examination, always remember that you have to rule out placenta previa via transvaginal ultrasound unless it is very clear, okay, because never do a speculum examination before ruling out. Rule out and then do a speculum examination, but basically we won't have time for this is just a theoretical point, okay. So now how are you going to manage the patient? Basically it depends. A management of abruption is always termination of pregnancy, okay. So which route is preferred? You are going to prefer a vaginal delivery, okay. In placenta previa we were preferring a C-section, but over here we prefer a vaginal delivery, okay. And we can also augment the labor. No issues in augmentation, just we have to terminate the pregnancy somehow, deliver the fetus somehow. So vaginal delivery is preferred. But if there is fetal distress, let's just make a flow chart now for algorithm. So if the fetus is alive, this is from DC data, okay, because 10 teachers has not mentioned this in detail, and an essay question or an OSPI question or a Viva question always comes, even an MCQ comes. So these two topics are very important. So fetus is alive or dead. Now if the fetus is alive, we are going to see whether fetal distress is present or not. If the fetal distress is not there, fetus is normal, okay, healthy and no distress, then you are going to do a vaginal delivery, okay. A vaginal delivery can be done. You can also augment the labor if you want to, if it is getting prolonged. And if distress is present, then in case of distress you are going to do a lower segment C-section always, okay. So it depends whether the fetal distress is present or not. But if the fetus is dead, then in that case you will have to do vaginal delivery. But we are more concerned with the alive fetus, that we are always going to prefer vaginal delivery unless the fetus is in distress. Only then we are going to go for C-section. But in placenta previa we always did C-section if the if the female was unstable. Otherwise we did conservative management, which was the McCafe protocol.